Good afternoon, and we're Thursday before the long weekend, and this was the week about 2 weeks ago today when our numbers coming into Canada from Ontario and specifically from other areas dropped significantly over the next day or two down to about 13,000 daily in that. So we should be finishing off a lot of our travel-related cases in that regard. And as I said, as we go forward, we're going to monitor to see how well we have achieved our goals with the physical distancing in that regard, and comment more of that in a moment. In that. And of course, a lot of the talk in the last day or so has been on testing, and I did put out some more on guidance update we did from the ministry on that, and I will speak to that in a moment. But first, let's look at the daily numbers here from Dr. Yaffe on COVID-19.
Okay, thank you. So as of 4 p.m. yesterday, the data from the public health database, 5,759 confirmed cases of COVID-19 in Ontario. This represents an increase of 483 from the previous report, and 37.5% of them are 60 years of age and older. 52.5% are from the Greater Toronto Area. At this point, unfortunately, there have been 200 deaths reported, and this is an increase of 26 deaths from the previous report. We are now aware of 69 outbreaks in long-term care homes, involving a total of 88 deaths, some of which were lab confirmed, some not. We do continue to see an increase in the number of resolved cases. We're now at 2,305, which represents 40% of the cases. We have cumulatively 622 healthcare workers who have tested positive. That is not the number that are currently positive. That's the number from the beginning till now. 632 of our cases are currently in hospital, and of those, 264 are in intensive care units, and of those, 214 are on a ventilator. In terms of the lab testing, at this point we've tested almost 89,000 people in Ontario. Only 1,208 are currently under investigation. In the last 24 hours, we've processed over 5,000 tests involving close to 4,100 people who have been tested in the last 24 hours. I'll turn it back to Dr. Williams now.
Thank you. And it's important to note, as Dr. Yaffe pointed out, that when we say we have 5,759 confirmed cases, that doesn't mean at this moment. That's since we started back in January. And of course, when you note all the ones that are resolved, so we're talking about 60% of that number. So that's what's active, and more being resolved every day in that. So when we talk about the tests and test results in that, and of course, we're trying to get an update from our modeling. As you know, when we had our modeling projection back over a week ago, or just about a week ago, it was noting that the cases, if we were following tracks of some of the more dire tracking, that we would be doubling our numbers at least every 5, if not every 7 days. So that means from last week now, we should be reporting numbers in the 800 to 900 range daily. And we're not seeing that. So that's one point of reassurance in that regard. And as we said before, we're hoping to get sometime perhaps early next week, as our modelers get some more detailed and more data, up-to-date data, to have them give us the new projections and see how we're doing in regards to our public health measures, as in the physical distancing in that. And that's why it's important to continue over this weekend especially, and I'll wrap up with that in a moment, to do and maintain our vigilance in that regard, because I can see already we're having success, and you're all doing collectively a great job, and we need to pursue that even further over this weekend. In the testing side there, as we followed up from yesterday, we have worked with our planning groups and various expert panels to look at the various things that we should be dealing with here. And in the testing one, we put out a lot of aspects related to enhanced testing in the long-term care setting and retirement homes. That's the group that has one of the highest vulnerabilities in the COVID-19. And it's one of the ones where we're seeing a lot of outbreaks in and a lot of cases. And it's been a challenge across Canada to how to deal with this. And today we were just looking at, with our federal, provincial, territorial committee, at the national long-term care management guidelines, and they're pretty consistent with what all of us are doing. And each one is trying to look at what further steps can we do to try and prevent, if not curtail, the influx of COVID-19 into these populations. And so everybody's putting the full package into it as much as they can and trying all sorts of different ways to deal with that, as we are doing here with my guidelines, or not mine, but the province's guidelines on that there. I'm going to do a lot more tests on a daily basis from the various settings in a wider scope to try and monitor it, assess it quicker, respond in a faster way to any potential cases. And I said before, we're getting more and more outbreaks reported from the long-term care community because we lowered the bar so much that we're probably going to get a number of false alarms. As I said before, I don't mind false alarms if they can be ruled out fairly quickly in that regard. We've also enhanced more aspects around caregivers, care providers, and first responders as far as getting priority testing in that regard. A lot more with rural, isolated communities, including First Nation communities, Indigenous communities, as well as dealing with other priorities in case contact management. And throughout this process here, we've also said it's important to note from the get-go, and I was making sure I was correcting some comments that the minister was trying to respond to, that we had told physicians that they can't, or they would not be allowed to do testing. We've never said that. Physicians, if they have a clinical concern about a patient who is symptomatic and they feel they need to be assessed for COVID-19, right from the start, those tests were not turned away. Those tests were processed and the results given back to the requesting physician in that regard. And that's still the case. And we're still saying that those individuals who are concerned and have symptoms compatible with COVID-19, and you can see there's different things added in the guideline, they should, if they feel it's more than mild or they're concerned at all, they should talk to their healthcare provider or go to an assessment center and ask them. And those doctors in those settings have the full proviso to do as much testing as they feel they want to deal with the clinical concerns that are presented to them in those settings. So there's no attempt here to curtail that activity on behalf of our our physician community involved in the various aspects of this here. So I think as we roll this out, and we have more to say about that in the next few days, we will see that the number of tests that are going to be utilized to cover these things will rapidly rise, and we're going to see the impacts of that over time as we pick up and make sure we're dealing with these high priority groups. One thing I wanted to clarify, there's sometimes a big confusion here, is that people feel that laboratory testing is for population-wide assessment all the time. That is not the case. Right from the beginning, these are for priority testing. The goal, as I said before, from this whole process is to decrease morbidity and mortality. And the testing is done in such ways that drives our programs and our services in an attempt to limit and to do that. While people may have a desire to know, it's more important that they know what to do. And the advice that we're giving through our public health sector, through the self-assessment tool, telehealth, and our assessment centers is that in some cases, and people have reported this, their case of COVID-19, even if it wasn't tested, is very short and very mild, especially for some of the younger people. But everyone is different, and some people can have symptoms that are very mild, and it can exacerbate or increase over time, and those ones should be reassessed again and perhaps seen in the emergency department or admitted and have further testing and handled accordingly. So I want to make it clear that there's no sector in Canada that does population-wide testing of everybody, and I haven't seen a country globally that has done that. Some have done quite a bit, such as South Korea, but no one has attempted to screen everybody in a country in that. So I think we have to be clear on that. And as we go forward, our goal is still to make sure all our testing is targeted at informing us of how to protect our vulnerable populations, how to keep our curve bending, how to keep the flattening of it, if you may, and to attempt to reduce any mortality and morbidity down from what the projections had shown in a rather dire prediction in the past and what we've seen in some of the other countries. And so that is our target here in Ontario. So with that, I'm going to open up for questions and from the line. Thank you.
We'll take questions from the first caller.
Your first question comes from Colin DeMello with CTV News. Please go ahead.
Hi, Dr. Williams. So I just got off the phone with a man who says his whole family believes they've had COVID-19. And they went to their family doctor and they went to public health in the region that they're in and were told that they could go to an assessment center but would likely not get a test, even though that they were exhibiting symptoms. And this is within the last week. So can you explain to me, because it seems to be a conflict with what you're saying, that clinicians are being told that they can give these tests. Why are people who have symptoms, why are they being told these things and being turned away from assessment centers?
Well, the information, what that doctor said, what would happen at the assessment center is that's one doctor talking about how another doctor might deal with the matter. And I hope that was an informed comment and not otherwise. I think if the physician who sees the person, much like if you see someone during flu season and they have signs and symptoms of influenza, but it's fairly mild, you'll probably say you need to go home, take rest, and you give a number of instructions, don't go to work, and keep yourself away from the rest of the family members and that kind of aspect there. But if you have some further problems, please contact me or come back and we'll reassess you at that time, simply because there isn't an antibiotic to give or anything to deal with at that moment. And they're more concerned about the overall health of the person and how they are doing at that time and what other supports they might need during the normal course of influenza in that case, but in this case, COVID-19. So what a physician might prescribe or ask for at that time, I think it's up to the individual physician, and that depends on a number of factors. One, the patient, their health conditions, their vulnerability, and other health matters that the physician, especially if it's their family physician or healthcare provider, would know the details of and what other precautions to take in that regard. And if testing was going to help influence in further decisions, I think they would undertake that. If they had advice most to just take rest and do different aspects related to the COVID-18, then they may not choose to do the testing because in their minds it wouldn't change their advice. I'm sure they would say if anything happens, please come back and contact me for follow-up. So in that sense, our physicians are dealing with this as any viral illness and want to give advice and direction that is useful, safe, and healthy, and one that endeavors to encourage not only the right behavior but also the right follow-up and management of the case there. As far as the individual and the family, we've always said if there is a group or a household that have traveled and someone of the family becomes, because they're all self-monitoring, and someone in the family develops symptoms, right away they're to isolate from the other members, wait to see if they get assessed or not. If it's mild in that, they should still continue to isolate and keep away from the other members because the other members at this time are still self-monitoring. If other members get ill, then they will have to self-isolate, maybe on a different timeline. In the 14 days, usually, as I said, from the younger groups, they tend to resolve on their own. But if they don't, then they're supposed to contact back again and to go in and get seen and assessed. And some may have to be admitted, unfortunately, to a hospital and have other further care. So I guess that's my answer back, is that how each one is handled by each physician, I can't say exactly because each healthcare physician is responsible for how he or she deals with the patient at that time. And based on the information they have and their clinical assessment, they will give advice accordingly. So whether they do test or don't test, I can't force them one way or the other in that sense. They make that decision based on the clinical situation.
Follow-up?
And so then how are you confident that everyone who is presenting with symptoms is actually going to get a test if you're saying that you can't actually force any one healthcare practitioner to administer these tests? It seems like what the command table or what you as the Chief Medical Officer of Health is saying isn't necessarily being acted upon in the general wider medical community. So what guarantees do you have that if you say we should test either a wider population in the days to come, that order or that request will actually be acted upon if you can't force people to do anything?
So what I said at the outset, the testing is not meant to do population-wide assessment. The testing is to assess the person's situation, especially if it directs their clinical care. Testing is also meant in certain settings to rule in and rule out for decision-making of handling, like testing a client or an individual in a long-term care home. Do you have a case in a long-term care home? Do you have to start implementing an outbreak management program in a hospital? Do you have an outbreak in a hospital? Does it direct your PPE for your nursing staff or your other staff, other caretakers, all arrange them in the hospital setting, yes or no? Does it help the physicians make decisions on ventilation, other therapies of severe cases? So testing isn't done just for the sake of population-wide screening. And the physician may say, because it's fairly prevalent around the community, they may say, well, all things considered, I think you probably have a case of COVID-19. Right now, you're just having a little bit of a cough. I would suggest that whether I test you or don't test you, you're going to be going home, you're going to isolate, not be involved with other people. And after a number of days, you'll probably reduce those symptoms. And while the 14 days are over, then you can return to more integration with the rest of the community. In their minds, nothing's going to change whether they get the test or not get the test. But if the physician feels there's some other points in this person's history or in their medical condition that I'd like to have that test, I need to know what that is because that's going to affect how I'm going to make some decisions, then they should, and they probably will, go ahead and order the test.
Next question.
Your next question comes from Jessica Smith with Queen's Park Briefing. Please go ahead.
Hi, thank you. I was hoping to ask you about the ICU numbers. There's some data from Critical Care Services Ontario on suspected ICU cases. Are all of those people tested, and then are they ruled out or included as confirmed cases within a matter of days?
The numbers that I gave about the number in ICU, the number on ventilators, those are all people who have been tested and confirmed to have COVID-19.
Suspected, not confirmed.
They are confirmed cases of COVID-19 who are either in ICU or also in ICU on a ventilator.
Right. I'm not asking about the numbers you gave. I'm asking about the figures from Critical Care Services Ontario, which includes numbers for suspected cases. Are all the people who are considered suspected, are they all tested, and are they ruled out or included as confirmed cases within a matter of days?
That is what should be happening. I know that they have had in the past, I'm not sure right now what the number is, they've had a significant number of suspect cases, and I've been in communication with the people who run that system to clarify that really, obviously, those people are extremely high priority to be tested and should either be ruled in as a confirmed case or ruled out and not as a case. But so I'm not including those numbers at this point.
Follow-up?
To follow up, it looks like the model data for Ontario ICU is expected more ICU patients now than the actual data is showing. Is that positive, and is it significant?
Could you repeat the question? I didn't hear it all.
Sure. I asked because the modeling data shows that there were expected to be more ICU patients in the ICU, COVID patients in the ICU, than there actually are at this point. Is that a positive sign, and is it a significant one?
So, yeah, I mean, I'm taking it as much like I said with the cases, and some have asked this question before because our modelers didn't use just the number of cases because that's quite variable, depends how you do the testing, but as long as you're doing some, you monitor that, and the prediction was that we would be double that number, around 800 or 900 daily. We're not at that level. And they also follow ICU admissions as well as deaths in that line there because they have a certain more solid, consistent predictability on that level there. So they did project that we would be with the, it depends on which trend we were following, we would be at a lot more cases by the end of April, or moving towards that. Our number of daily amounts of new cases should be increasing considerably as well. Of course, then the flow out from that is that you would have a lot more ICU admissions and a lot more vented, and a lot more deaths. So as you noted, we're below what was projected, and they said they would not be surprised, or they would hope that would happen. They said if we did more concerted action around our public health measures, they would be advised by that data, and that we're hoping to give our reports and data over the last week and a half, or until next week, and they were hoping to give an update to us of what the new projections are, and to see if we have been further successful in bending the curve, as you're inferring by the lower number of ICU admissions and what we had anticipated.
Next question.
Your next question comes from Sean Jeffords with the Canadian Press. Please go ahead.
Hi, Dr. Williams, Dr. Yaffe. Dr. Williams, I'm hoping you can explain how the province could potentially ramp up test processing to the point where the Premier has asked it to be at 13,000 tests a day. I understand from Dr. Yaffe's report it was around 5,000 processed tests as of today. So how could those tests be ramped up, and how long would it take?
Right. So because of our size, it's not that hard to ramp up those tests. The difficulty is that we could ramp them up so quickly, we would quickly outstrip even the 13,000. And we'd lose out on our priorities, and we'd be back to the backlog issue yet again. So we want to make sure when we ramp up and turn that dial up, one deals with the priorities, that's going to deal with the issues at hand and of concern to all of us, including our minister and to the Premier, is our long-term care homes and our retirement homes. If in my guideline, or the guideline that went out, if we undertake that, if you may, in the number of facilities we've got out there, ones in outbreak, ones that are coming onto outbreak, even if you got 200 to 300 of facilities that are undertaking some regular testing, and they do 5 to 6 or something like that a day, you've already picked up a large number of tests just in that alone, let alone all the other areas we could move up on. So there's a number of areas that we feel we need to queue up on and to do much more intensive testing in priority areas. So I have full confidence through our members in Ontario Health, as well as with our consultants, that as we utilize this asset of more testing capacity, we will do it in such a way that we can maximize the benefit of our looking at our priority groups in that area, as well as the ones that are coming from assessment centers, of course. And some of those physicians may be sending more tests in as they've heard all the discussions, and there might be some desire to do that, or some more clients come with some other issues that they want to test on. So I think that number will go up. The concern is that it could go up really high, and we want to make sure we don't get back into a large backlog number again, so that our priority groups and ones of most concern would be waiting for longer periods to get testing back. So stay tuned, and I think both the Minister and the Premier will be talking about that, as well as our consultants, on how the plan to use up that capacity fairly soon.
Follow-up?
Doctor, by way of follow, I just wanted to ask you about your directive that you issued today regarding healthcare workers, and specifically the continued recommendation that they not work in multiple homes. Why is that still a recommendation and not, mandatory, as the Ontario Nurses Association and the registered nurses have requested?
Right, and we have right now strongly recommended and asked that those who work in multiple settings and that they notify their employer of which locations they're in, assuming they are other healthcare institutions. They may have other part-time jobs outside, for all I know. And because then if there is an outbreak in any one of those, they're going to be asked to not work in any of the other facilities, and they may actually be off on a period of quarantine related to their exposure or potential exposure in the one they're in. As far as making it mandatory, we're working that through with our partners in the Ministry of Labor in that, as well as the legal grounds, and to understand what we might and could do in that regard to entertain that. And so far we've been addressing the fact that they have been notifying other employers accordingly, but we're continually monitoring that process. I noticed that we just got off with, as I said, with our Federal, Provincial, Territorial Committee, and the topic we discussed there was what to do about people who work in multiple settings. And each province and territory is struggling with the same issue in a way that protects those at risk, but respects the rights of the individual, working in those settings as our democratic process allows. And so we're trying to understand that and how best to work out a solution that's amenable to all and for the protection of those most vulnerable.
Next question.
Your next question comes from Mike D'Souza with Global National. Please go ahead.
Yes, hi. Thanks for taking the call. And my question, I'm guessing you've heard the survey results released earlier today by the Canadian Union of Public Employees regarding what workers, personal support workers, are saying about their level of training. I think that 95% of them say they've had no access to training. We've also seen images of workers wearing personal protective equipment outside facilities such as Pinecrest. What can you say about the level of education right now of personal support workers, and do you believe at this time that they are properly educated and trained about best practices, and what would you recommend as a solution?
So I haven't seen the survey, so I can't comment to that explicitly in there. With any of our workers, be the personal support workers or home care or in hospital and staffing, it's been a concern from the start that they have adequate knowledge on what is COVID-19, what the risk factors are, what kind of personal protective equipment they need to use, in which settings, what kind of procedures or settings they might get involved with, that they need to take precautions or further accordingly when they don't need to take precautions, and what kind of things you have to do when you're off the job, because you can be exposed in these days as likely in the community, because as we said, we have a number of people that have a reporting that they didn't travel or had a contact of a case known. So you have to do your a wise handling of yourself both on and off the job in that. So always want to be doing more training and education, and if that's a useful survey, we'll be informed by that. And again, that's part of the challenge of each organization has to work with their staff, one, to say, what is our knowledge base? What kind of training do we need to do? How much in-service education? Even you've heard some of the very tertiary hospitals practicing again and again through this so-called doffing and donning of equipment fairly quickly in urgent situations, because it may seem on paper easy, but when you start to do it, you have to practice and do it. And so that ongoing education and training is critical for all levels. And so I would be supportive of the ongoing training education of PSWs, such that they would be totally informed and aware what they might or should do in every situation.
Follow-up?
Yeah, thanks. I'm not sure I understand, though, why. I mean, I understand it could be challenges at some institutions or facilities, but ultimately, whose responsibility is it to make sure that this is done, and why hasn't it been done yet?
In the plan, the responsibility is that of the administration of the organization. So the administration of the hospital, of the long-term care facility. Retirement homes are a little bit different, but we're asking them to take the same responsibility. The home care agency that's supplying those services, they have that responsibility to undertake to do that.
Next question.
Your next question comes from Kenyon Wallace with the Toronto Star. Please go ahead.
Hi, doctors. Thanks for taking my call. Do we know, are we short any testing materials in the province? And if so, what are we short on?
Currently, we're not short of any testing materials. Now, that may not stay that way for forever, but that is currently the situation.
Follow-up?
Okay. Yeah, and do you have, this is maybe, Dr. Williams, you may have already addressed this in a different way, but I just wanted to get clarity. Do you have any plan at all to test the general public outside those 7 groups you highlighted this morning?
So, as I said before, the testing of the general public, as in a population-type survey, we haven't been given that recommendation yet by any of our epidemiologists or our modelers, per se. I would said before that no country does general population surveys in this time because they're dealing with the urgency of it in there, because you wouldn't have to say, what is the purpose to get a general sense of the population who have had no exposure, no history, no signs or symptoms, to see what the positivity rate might be. And that may be informed better in the future when we acquire the better or the more, at least seem to be highly touted, serology testing methodologies to look at to say, in overall, what was the immunity of the public after the event, and how many people may have got exposed. And as we found in some cases and others in the past, that people said, I didn't know I was, but I've developed immunity, so I guess I must have had it. I didn't even know I had it. So there's a difference between serial surveys of the public versus the testing we're doing now is more for looking at predicting ideas of infectivity and various priority purposes to meet that. So no, we haven't been planning to do a population survey with the PCR at this stage, but it doesn't mean that we won't be considered something in the future as we get more technology around doing population surveys of exposure to the coronavirus.
Okay, unfortunately, that's all we have time for. Thank you very much.